Huh? I don't know how to do all that.
Okay, so your computer's not showing. It's good. I think Lanny.
You hear me now? Hello.
Yeah.
The mic is not working now. No. Not on my. Is it coming? All right, let's see. Looks like almost everybody's here anyway.
I can hear, but I think
Can you guys hear me at all?
yes.
Okay, somebody says yes. Who's saying yes? A little bit? Not very loud?
How do I turn off the microphone? Oh my gosh.
There's a little mic button and just click on it. It'll put a line through it. I might be able to mute people. I don't know. F4 turns off your mic, is what I'm being told.
Hi.
Hey. Whoever that was.
Mr. Roberts, can we have a tour of your house?
Yeah, Mr. Roberts.
It's a total wreck right now.
So, yes.
I mean, I can take this off and show you my unfinished office, but that's about it.
We miss you. Come back.
Miss y'all. All right, bye. Can you guys hear me then? Some of you? Is it loud enough? Yes. Yeah, okay.
Yeah, dog.
Yeah, dog. All right, we're gonna give this our best shot. I don't know. How y'all doing?
Good. Should we shut this off?
I don't know. Doesn't matter to me. It's kind of nice to have somebody to talk to.
You can't see me, right?
Okay.
Okay.
So what do you guys see? Are you seeing my computer screen?
Yeah, we see your computer screen, and there's a little square of you up in the top.
Oh, okay. So don't do anything crazy then. All right. Okay, I was going to try to pull it up where I could just do the PowerPoint, but that's not. It doesn't seem to want to do that. So anyway, we'll just do it this way, if that's all right. Oh man, wait a minute. Now what do you see?
The PowerPoint's bigger. Yeah, it takes
Okay.
up the whole
Is that
screen.
better? Okay. All right. Okay, everybody ready? I can't see the chat that way though. That bothers me because somebody has something they need to do. So there's group chat. All right. We're getting there. Maybe not. Sorry. What have I done? Is that good enough? Can I do that? Does that work okay?
Yeah, that works.
Yeah, okay. All right. So here's the game plan for today. We've got a couple different things we need to talk over, and we're going to start out with what's called axis. I think it's a term we've used some in the past. Really, axis just means it's the main wave of electrical activity. You know what I mean by that? Those of you who are there to listen and respond. So we can measure the axis really in any part of the EKG, whether that be atrial depolarization, ventricular depolarization, or even ventricular repolarization. And all we mean is the EKG, the heart's got electrical activity going in all different directions at one time. The only thing it's able to pick up is kind of the main wave of electric, right? So that's what axis means. And if you think back to when we talked about sinus rhythm and atrial depolarization, then you know that when the SA node depolarizes, it kind of shoots things down and to the left, and that's the axis of the electrical activity or atrial depolarization in the sinus rhythm, right? So just that main direction of electrical activity. So that's what we're going to talk about today. That's number 3 on your 5 major categories of EKG interpretation. Everybody with me so far? Thumbs up. Maybe. All right. We'll just hope so. And that's not working. Why is it not working? It's bigger now, right? Okay. So the EKG really, again, is showing electrical activity. That's the main thing going on at any given moment in time. When we talk about the electrical axis of the heart, the main thing we're concerned about when we evaluate this number 3 out of number 5 things is the wave of depolarization in the ventricles. So if we're talking about depolarization of the ventricles, we're going to look at what part of the EKG. You can say it yourself out loud. The QRS, right? The QRS is what's showing us ventricular depolarization, and so that's the thing that we need to pay special attention to when we're trying to determine the electrical axis of the heart. And so we're going to pay attention to the QRS complex, and we're going to look at that in what's called the frontal plane. So frontal plane is from top to bottom and left to right. And if you'll remember the hexaxial diagram hanging up on the front wall in the classroom, those are the leads that read in the frontal plane. So we're going to have to pull out our knowledge of the hexaxial diagram again in order to have a good understanding of the electrical axis of the ventricles and on the EKG there. Like I said, you can determine the electrical axis of really any part of the EKG. the atrial depolarization, ventricular depolarization, ventricular repolarization. But for this purpose, we're going to look at the QRS complex and the depolarization of the ventricles to kind of get a general idea of what's going on. Now, the electrical axis does not give us very specific information about what's going on in the heart, but it kind of gives us a list of possibilities to look at, and we'll describe that a little bit as we go. Okay. So the electrical axis, we're talking about QRS depolarization or depolarization of the ventricles. So we're looking at the QRS complex. What we know is that the QRS is kind of demonstrating is narrow whenever we get normal conduction by way of the His-Purkinje system. The His-Purkinje system being the AV node, the bundle of His, the left and right bundle branches, and down into the Purkinje fibers. So all that should be kind of what we're talking about with depolarization. And when that happens, the left and right ventricles should depolarize at the same time, but the electrical activity is going to shift towards the left side because the left ventricle is bigger, right? So more electrical activity on the left side means that our wave of depolarization looks like it's on the left side. So the normal axis of the ventricles is down and to the left. We've talked about how down and to the left on your hexaxial diagram is around lead 2, right? See that over there on the hexaxial diagram, everybody? Good. Man, I hate not being able to see people's faces. Okay. So the normal axis of the ventricle should be kind of down and to the left. It's starting at the AV node, it has to go down. It's going to go to the left towards that larger left ventricle where more electrical activity is happening. So normal electrical activity, normal axis should be over in the bottom left-hand corner on that hexaxial diagram. We'll describe what that'll look like in a minute. So when there's not any disease processes going on, it should fall somewhere in that left lower quadrant on that hexaxial diagram. The exact range of a normal axis is going to vary from source to source. Some would say it's going to be between 0 degrees, which is where lead 1 is at, and positive 90 degrees where AVF is at. So it's saying that the electrical axis should follow somewhere in there. Some people are a little bit more judicious with that and say it can go up to negative 30 degrees where AVL sits and all the way over to lead 3 where it's 120 degrees. Probably the simplest, the way I'm going to teach you to calculate an axis today is going to be fall more in that narrow range where it's going to fall between lead 1 and AVF. And that's just because it's simply just the easiest way to do it, and you can learn it that way. Okay. And all this may not make complete sense yet, but hopefully as we talk, you'll see what I'm talking about where it'll fall into those specific degrees and areas. So under normal circumstances, we should get a fairly normal axis, but there are a few things that can cause the axis to shift out of that normal range. Number one would be an actual change in the heart position. And I think I've got some separate slides on this, but the change in the heart position can vary by your body habits. So if you've got a real tall, slender person, that heart's going to sit more upright in the chest like this. But if you get somebody who's pregnant or obese, as their abdomen kind of pushes up on them, that heart can then shift and kind of change position inside the chest and can sit more laterally like this. And so that's a possibility that maybe just the change in the actual heart position itself can cause the axis to go somewhere else. So ventricular hypertrophy, we talked about this in pathophysiology, but if you've got systemic hypertension, right, the left ventricle is going to have to work harder to overcome that pressure. And over time, just like lifting weights, that the left ventricle is going to enlarge. That means there's going to be more electrical activity over there on that side. And so the axis will shift in the direction of ventricular hypertrophy. So that would be one thing that can cause the axis to shift, is an abnormally large ventricle. Myocardial infarctions can also cause the axis to shift. What happens when there's a myocardial infarction? Well, the tissue is dead, and dead tissue does not depolarize. There's no electrical activity in that dead tissue. So the axis will actually shift away from the area that had the myocardial infarction. So because there's no electrical activity happening over here, all the electrical activity is happening on the other side, and that's where it's going to show the most electrical activity, and that's where axis is. And then some electrical conduction problems, such as these vesicular blocks that we're going to talk about a little bit later on. Some electrical conduction problems can cause the axis to shift. So these are the big 4 categories, and you can break them down into tons of separate things, and those will be found in your book. And I don't have it in front of me, but in the chapter this is coming out of, there are some tables that show you when you have a certain axis deviation, what the differential diagnosis could be for that. All right, so abnormal axis, a change in the heart position. So right ventricular overload, you've got higher pressures in the pulmonary artery from pulmonary hypertension, and the right ventricle is going to start getting overloaded. That can cause the heart to kind of tilt over more towards the right, and you can get a right axis deviation, simply from the actual change in the position. And then body habitus, like I said, can alter the axis as well. Hypertrophy, we've mentioned this already. The larger the ventricle is, the more electrical activity that's going to happen there, and so that can do that. So if we see an axis deviation, we might towards the left, we might assume that there could be some left ventricular hypertrophy. In a patient we know who's had long-standing hypertension, and we put that together with these EKG findings that show us this left axis deviation, then we know why that might be. And so that's kind of one of the things. So hypertrophy is one of your big differentials you can consider. Like I've already said, the axis will shift away from the myocardial infarction. If you've got dead heart muscle, when it shifts away from that, there's no electrolyte depolarization happening there, so the electroactivity is going to happen further away from the myocardial infarction. Hope that's making sense. Electrical conduction problems, the fascicular blocks, and we'll get into those in just a minute. It's raining outside. Right, so a normal axis, depending on, again, what book you look at or what source you look at, can be somewhere between -30 to positive 120 degrees. For our purposes here today, what you can, when we figure it, we're going to consider a normal axis between 0 degrees and positive 90 degrees. And the reason being is you can see down there in the bottom right-hand corner of the screen here that we can break this hexaxial diagram into 4 quadrants, and that makes it really easy for us to locate the axis and then kind of place it whether it's normal or left or right. We'll talk more about that next. Anybody? Oh, just making sure. Yep, everybody's still good. All right. All right. So if it's not inside that normal axis, we have 0, positive 90 degrees. The next thing we look at can be what's called a left axis deviation. So left axis deviation could be, and on the screen here it says -30 to a -90. For us, we could say it's 0 to -90 degrees. So basically, we're looking at the area from lead 1 that points directly to the left up to the top there where it says -90 straight up. So somewhere in that quadrant, the upper left-hand quadrant, would be what's called a left axis deviation. Sometimes as people get older, you may get a shift in the axis to the left. Again, with people who are pregnant or obese, as that heart kind of shifts and turns, that it can turn on its side actually the other way to the left, and then you can get more of the left axis deviation from that. Left axis deviation with a left ventricular hypertrophy from systemic hypertension, and an inferior MI would cause it to shift to the left, and then something called a left anterior fascicular block that we'll talk about. This is where one of the fascicles of the bundle branch is not working normally. Right axis deviation, this will be from positive 90 degrees, so straight down at AVF, all the way over to positive 180 degrees, so that bottom right-hand side on that's the right axis deviation. So body habitus, hypertrophy, MIs, shifting away from that, shifting towards the hypertrophy, and fascicular blocks can all cause a right axis deviation. Extreme right axis deviation, that's that way up there where AVR is at. And so that corner of the hexaxial diagram is extreme right axis deviation. Right, so how do we do all that? What does all this mean, and what are we doing to figure this out? So you need to make sure that you have a solid understanding of the hexaxial diagram before you do that. If I was sitting in class, I'd probably pause everything here and say, draw out the hexaxial diagram just to make sure you understand it. I think most of you probably have a pretty good understanding of that now, but if you've got a piece of scrap paper handy, maybe take a minute and sketch out the hexaxial diagram just to help you to make sure you understand it. And you're probably going to want to mark some things down as we do this to maybe help you understand it a little bit better. You also need to know the 4 laws of EKG, and I think that's on the next slide here. where basically we have a wave of depolarization going towards a positive electrode. It's going to give us a positive deflection on the EKG. The wave of depolarization going away from the positive electrode will give us a negative complex on the EKG. And then a wave of depolarization going perpendicular to the positive electrode gives us this biphasic wave. Now, equiphasic is a term I want to kind of throw out there too. Biphasic and equiphasic are similar. Biphasic means there's an up and down portion to the wave, but equiphasic would mean that the up portion and the down portion are of relatively similar size, and that'll come into play here in a minute when I give you kind of another way to figure out the axis. Okay, so make sure you know the hexaxial diagram and understand this, and I think most of you should be able to shape it. All right, this is the easiest way to figure out the axis, and all this stuff might sound complicated, but it's getting ready to get pretty easy. Okay, this is not that bad. This is a method that comes from Dubin's book, okay? But so Dubin came up with this idea, or at least he mentions it in his book, and that's where I learned it from. So if you break down the hexaxial diagram into these 4 quadrants, the bottom left, remember that's where the main wave of depolarization is going to go normally, so that becomes our normal quadrant. The upper left-hand corner there is left axis deviation, the bottom right-hand corner is right axis deviation, and then the upper right-hand corner being that extreme right. And really, we can figure out the axis by looking at 2 leads, and that's it. All we have to know is what's happening to the QRS complex in lead 1 and in AVF. The reason that's what we need to do is because lead 1 sits directly on the left side. Remember, the positive electrode's over there on the left arm. And so anything going towards lead 1, if we get a positive wave headed towards lead 1, then we know that the axis is shooting towards the left side of the body. And so immediately, we can shade in the left side of the circle and know that the axis is somewhere on the left half of that. So it's either a left axis deviation or normal. And I'm going to try to pull up my iPad here in a minute and show you what I'm talking about. And then if we look at AVF, if AVF is positive, then we know that the axis is pointing down towards the bottom. And we use those two pieces of information in order to try to put together the axis. Let me see if I can. It worked when I practiced. All right. Yeah. Okay, can you see my iPad now? There? Yeah, maybe. Okay. All right. Let me see if I can find the right. We'll just do a blank one here. Okay. Okay. So I've got the 4 quadrants. You guys see that okay? All right. So if I get a pot, so if I look at lead 1, what I want to do is look at an EKG and look at lead 1. If that QRS complex is upright, what that tells me is that that my axis is going to be over here on the left side of that quadrant. So if I've got an upright complex in lead 1, then I know that my axis is somewhere over here on the left side. Okay. Same thing with AVF. If it has an upright QRS complex in AVF, then I know that my axis is somewhere down here at the bottom. Okay, because it's going to be pointing down towards my feet. And where those 2 things overlap is where my axis is at. And so if I've got an upright wave in lead 1, an upright wave in AVF, then I've got a normal axis. Okay, and so because it's going to hit right there in that quadrant. Does that make sense? Maybe. All right, we'll try to do another one here real quick. Look at 1. This is like the hexagonal diagram, right? So if lead one has a negative QRS complex, it's pointing away from the left side of the body. So where would you think, I'm going to shade in this diagram at, right? Over here on this side. So the wave of depolarization is going away from lead one when I've got a negative QRS complex. It's going in that direction, so my axis is going to be somewhere over here on this side. If AVF, we'll say AVF remained positive, then we'd still shade in the bottom side, and where the two meet is going to be our axis. So you know that's the right axis deviation. So that's all we're doing here is find out what happens in lead one, find out what happens in AVF, and shade in your thing, and use your little quadrants to show you there. And I wish I could flip back and forth, and that's what you would do. Yeah. So depending on where you shade things in at, you're going to hit one of these quadrants, and that's all you got to do. Right? Okay. All right, so the quadrant, basically lead one has the positive electron in the left arm, right? So lead one has an angle of orientation. Here's where, I don't think we talked about the numbers so much with the hexaxial diagram, but there's some numbers associated with these leads. So lead one has an angle of orientation of 0. So the left arm there, straight towards the left arm, has an angle of orientation of 0 degrees. AVF, that positive electrode's on the left foot and goes straight down the hexaxial diagram, and has an angle of 90 degrees. So when we talk about the axis being between 0 and positive 90 degrees, what we're saying is it's somewhere between lead one and AVF on the x-axis. All right, so the quadrants all represent an area. So the normal quadrant down the bottom left is 0 to 90 degrees. Left axis deviation in the upper left-hand corner is 0 to negative 90. Right axis deviation, positive 90 to positive 180. Extreme right axis. There you go. All right, so just kind of like we walked through a minute ago, you're going to evaluate the QRS in lead one. Start by doing that. See if it's positive, negative, or equiphasic. Okay, so it's positive, it's over there on the left-hand side of the quadrants. If it's negative, it's going to be on the right-hand side. Equiphasic, we'll get to that in a minute. Okay, evaluate the QRS in an AVF. Same thing there. Shade in where the two overlap. That's where you've got your axis. So here's an EKG right here. So get you a scrap piece of paper and go ahead and draw the quadrant down on that piece of paper for me, and draw the circle, and then put your quadrants there. Okay, so lead one, let's start with looking at lead one, and is it positive or negative? I have no idea if you're following me or not. Let's see. Okay, so lead one is positive, right? So what you need to do then is, that means that the wave of depolarization is shooting towards the left arm. So over there on your circle that you drew, I want you to shade in the left-hand side of that diagram. All right, so half of our information is there. All right, so then we're going to look at lead AVF. So come down here a little bit, look at lead AVF. Is it positive or negative? And positive, right? So that means that the wave of depolarization is also going down towards the feet. So you're going to shade in the bottom half of that circle. And what do you got? You got lead one and lead AVF both upright. And as Dubin would say, you got 2 thumbs up. 2 thumbs up means you got a normal axis. You got positive in lead one, positive in AVF, 2 thumbs up, you've got a normal axis. And that's done with that one. Okay? Make sense? All right, hope so. So here's another drawing of it. So lead one upright, you're gonna positive complex in lead one, shade the left-hand side of the diagram. AVF with a positive complex shaded in the bottom side of that diagram. And when you put the two together, where they overlap happens to be in the normal quadrant, so you have a normal axis in this patient. Okay. All right, so the other way to do this is what's called the equiphasic method. It gets a bit more specific with the axis, but this is just another way to skin the cat. Do you need to know every one of these? No, I think the quadrant method's sufficient. Okay, this is just another way that we'll quickly kind of go over. What we know by the 4 laws of the EKG is that when we get a biphasic wave, especially if they're of equal heights and depth, that we know the axis is 90 degrees away from that equiphasic lead. So one thing you can do is you can try to find a lead that is most equiphasic. And if you were to look at remember we're looking at the frontal leads, or the leads of the hexaxial diagram. So which one of these leads do you think looks most equiphasic, where the positive wave of depolarization and the negative wave are of equal heights? Somebody want to type it in when you're there? Yeah, ABL, thank you. So ABL is equiphasic. So what does that tell me? It tells me that my axis is somewhere 90 degrees away from ABL. Where's my hexaxial diagram? All right, so 90 degrees away from ABL, right? So that gives me a couple different options. So one, 90 degrees away from ABL could be somewhere near positive 60 degrees, which is lead 2, right? And that would be in a normal axis. Or it could be 90 degrees away in the opposite direction, which would be kind of up there in no man's land with extreme right axis deviation. So how the heck do I know which one it is? Well, I also know that by the 4 laws of EKG that a wave of depolarization going towards a positive electrode should be upright. So I can look at lead 2 and see what's happening with that. If I go back to this same EKG and lead 2 is completely upright, then I know that my axis is pretty close to 60 degrees. If lead 2 is upside down or inverted, then I know that it's headed up there into no man's land, and I've got an extreme right axis deviation. Okay, so we'll go back to our EKG. Let's look at lead 2. Lead 2 is super tall and positive, so it's telling me that my axis is somewhere close to 60 degrees, close to lead 2. Does everybody see that okay? Now I'll give you another little hint. The computer also tells you the axis. And so if you were to look up there at the top middle part of this EKG, where there's a thing that says heart rate 77, and then come on down from that, it's going to say P-QRS-T axis, okay? So that middle number there is the QRS axis, and you'll see that it says 54 degrees. And we came up with 60 by using the equiphasic method. So it can be pretty specific if you needed it to be. And now we know we've got a normal axis. If you didn't know by the 2 thumbs up, then you can do that method. You see that both get you into the normal axis, which is really all we're trying to figure out, right? Okay. Oh, here it was. I drew this on this one. So this one is also where you have an equiphasic lead in ABL. And we know that it's 90 degrees away from that. We look for our tallest R wave, which happens to be in lead 2. That tells us that our axis in this one is also close to 60 degrees. If you come up to the top left-hand corner, it'll tell you that our axis was 58 degrees. Completely normal, right? Bottom down to the left in that normal axis. That was what we're trying to figure out. All right, there's the computer interpretation for it if you couldn't find it on your own. Questions about axis? How am I getting 60? Okay. So ABL here is, let's go back to, we'll use this one. So ABL here is almost equiphasic, right? So the top part of the QRS and the bottom part of the QRS are almost the same height. And so I know that because it's an equiphasic lead that it has to be 90 degrees away from ABL. Does that part make sense? That it's not, so if I have an equiphasic complex, my axis is 90 degrees away from that. Does that make sense? Maybe? So what we're doing is we're going back to the 4 laws of EKG basically to come up with that. If I've got an equiphasic wave like this last one down here at the bottom, okay, then I know that the wave of depolarization is perpendicular to that, which means it's about 90 degrees off from that positive electrode. So that's what we're looking at when we get ABL. Okay, ABL is near equiphasic, so I know that my axis is about 90 degrees away from ABL. You go back to the hexaxial diagram, and we see that ABL sits in the upper left-hand part here at negative 30 degrees. So then I know the axis is going to be 90 degrees away from that. So 90 plus negative 30 is 60. Okay, which hits me right where lead 2 is at. Okay. So, or you can go the opposite direction and it'd be, what would that be? Negative something. Okay. All right, so 90 degrees off of that one. And since lead 2 is real tall, we know it's going down towards lead 2 and we get 60. All right. Any other questions about axis? All right, let's do bundle branch blocks real quick. How about that? All right, so going back to our understanding of the anatomy and physiology of the His-Purkinje system is important here, right? All right, so when we talk about or this wave on this one, now here's the thing about yes, you're right. When we look at the axis, though, Ryan, what we need to do is we're looking at it in the frontal plane. So you want to pay all you want to do is pay attention to these leads that are on the hexaxle diagram, not the chest leads. So V2, actually the most equiphasic in your chest leads would be V4, but that's not going to tell us anything about the axis. Does that make sense? We want to, for the axis, we want to look in the frontal plane, and we're going to use these leads over here. Yeah? Yep. Okay. Awesome. All right. So from the very beginning, we've talked about how to figure out where the rhythm originates from. And one of the things we've always said is that if we've got a narrow complex rhythm, we know the rhythm is supraventricular. Okay, so supraventricular rhythm. But not all supraventricular rhythms have a narrow QRS complex. So that's what we're going to talk about today is the bundle branch blocks and why some of these supraventricular rhythms will end up with a wide QRS complex. Okay, so what the narrow QRS complex tells us is that we've got normal depolarization down through the His-Purkinje system. So this picture over here on the right, where you got the AV node, the bundle of His, and the right and left bundles, down into the Purkinje fibers, all of that has to work normally in order for us to get the narrow QRS complex. But when that system is breaking down, when one of those bundles is not working appropriately, then we end up with abnormal depolarization in the ventricles, and we can get a wide QRS complex. And when that happens, we call that a bundle branch block. Okay, so what is it saying over here? Well, so yeah, we lose our efficient conduction. If the left bundle fails, we're relying on the right bundle, which goes to the right ventricle, to depolarize everything else. So it's having to shift everything from the right all the way over to the left, and that's going to take longer. So we'll get into that. Let me see if I can pull my iPad back. Okay, so when it comes to the QRS complex being made, there are two really big phases that I want to make sure that you understand and kind of come back to me with. So the wave of depolarization is going to start in the AV node, come down the bundle of His, and initially the left bundle will actually depolarize a little bit before the right bundle. So the left bundle happens just a little bit earlier. And what that will create is what's called a septal wave of depolarization, with a small wave of depolarization kind of going down in that direction. Okay. And as the depolarization will continue, they basically will become simultaneous down here. So the left and right bundles and the Purkinje fibers will fire at the same time. But even though they're simultaneously depolarizing, which side has the larger heart muscle? Well, the left. So the electroactivity is going to shift back over to the left side. So you will, and so you've got two main waves that you're going to kind of, or two main phases you're going to look at. Does that make sense? So you have the septal wave here going down to the right, and then you've got your big final wave going back towards the left. Is that kind of making sense? Okay. Go back to our screen here. Okay, so you've got two phases. Phase one, the left bundle is going to fire just before that right bundle. So we're going to get a little septal wave there. Okay, we're going to get what's called a septal wave when you get this left to right depolarization of the intraventricular septum. Phase two, as the wave continues down the bundle branches into the Purkinje fibers, then you get simultaneous depolarization of both ventricles, but because the left ventricle is bigger, there's more electrical activity over that way, and so our wave is going to move over into the left. Now, all this should be nice and efficient as it comes down through that His-Purkinje system, and that normal depolarization should take really less than 0.10 seconds. All right. Now, to know the direction that the QRS complex is going, the easiest way to do that is to look at the lead that's furthest to the right and furthest to the left on the chest. So looking at V1, which is the furthest one on the right side of the chest, just to the right of the sternum, and V6, which is the furthest to the left, just under the mid-axillary line over there. Those are going to be the ones that give us the easiest way to kind of make sense of what direction the electricity is flowing. Okay, so those are going to be when we talk about bundle branch blocks, V1 and V6 tend to be the most useful to help us to find that abnormality. Okay, so axis, we look at which two leads that help us the most. 1 and ABF. When it comes to bundle branch blocks, what two leads are we going to look at when we get the most information? V1 and V6. All right. A little bit more on the anatomy of the bundle branches. So you've got two main bundles. You've got the right bundle and the left bundle. Now, the left bundle is broken down into two what we call fascicles, an anterior and posterior. And you can have any part of those fail, and that would be considered a fascicular or bundle branch block. All right, so let's talk about a right bundle branch block first. So if the right bundle fails, and this is not all that uncommon, then you'll get what's called a right bundle branch block. This can happen in patients that have absolutely no heart problems whatsoever. It can come and go depending on the rate. If you get a faster heart rate and the right bundle hasn't quite recovered yet, it's still in that refractory period, you might see a bundle branch block occur. So it can kind of come and go depending on the rate. All right, so let's go back to thinking about the right bundle branch block in, try to get my iPad back right here. Okay, so what we want to think about is what happens when we get the right bundle to fail. I know, working on it. Okay, so that right bundle is not going to work anymore. So what's going to happen to the electrical conduction with that heart failing? Okay, so what's going to happen in the first phase? We're just going to start the AV node. It's going to come down. It's going to hit that and stop. It's going to come down the left bundle. Now, remember, the left bundle is the thing that fires first. Is that phase going to get interrupted by a right bundle branch block? Anybody? The answer would be no. It's not going to get interrupted. The left bundle is still going to fire. And it's still going to cause a wave of depolarization down and to the right. So phase one, left untouched. Okay. So phase two, as the wave of depolarization continues on down, we end up getting depolarization down here that does not occur on this side, but is occurring on the left. So my main wave of activity is on the left. Is that going to change the way that my second phase is going to look? Remember, the second phase normally is with both ventricles going at the same time, but that left ventricle has more activity, so it's going to shoot to the left. Well, in this situation, all I've got is the left side. So my wave is still going to move over to the left. Does that make sense? My oranges are getting all kind of screwed up. Stupid. That's pretty. Okay. All right. But now the problem is that the right side over here still hasn't had an opportunity to depolarize completely. The left is done, and the right is still kind of waiting. So we end up getting a third phase where the activity shoots back towards the right side of the heart. So we've got the normal phase 1, normal phase 2, and then an additional phase 3 when it comes to the right bundle branch block. So in V1, we get what's called an RS R prime, and I'll show you what that looks like if I get this back in. Okay, so the normal septal phase here in V1 is going to shoot over towards the right. It's going to go from the left bundle over to the right in that septal wave. The phase 2 is going to be that big shoot back towards the left, and then phase 3, we're shooting back towards the right. So in the right-sided leads, we're getting a big, tall R wave that shows that we're shooting the electroactivity back to the right ventricle to complete our depolarization over there. So some people will call this bunny rabbit ears. If you've ever worked around, EKGs before, people will say this is the bunny rabbit ears. But the bunny rabbit ears have to be in these right-sided chest leads in order to be something associated with a right bundle branch block. Okay, so R, S, and R prime is a pretty typical pattern for the right bundle branch block. Okay, is that making sense? Okay. Yes. Okay. So typical characteristics what we're looking for in a right bundle branch block is that because the depolarization isn't normal down through the ventricles, it's going to take longer. So that's number one. The bundle branch block is going to have a wide QRS complex, typically greater than 0.12 seconds. So that's what we're looking for. So 3 blocks in width or more, wide QRS complex, that's number one. Number two, for it to be a right bundle branch block, we're looking for this RSR prime morphology in our right-sided chest leads. So maybe that's in V1, but it's also possible it could be still the right-sided chest lead of V2. I think there was on the midterm maybe where people got confused because V2 is on the left side of the sternum. It's still a right-sided chest lead. Remember, your heart's kind of twisted inside your chest. So even though this is on the left side of the sternum, it's still taking a good picture of the right side of the heart. So this is the kind of morphology we're looking at. We're looking for a wide QRS complex. We're also looking for this RSR prime morphology. And then another important thing to think about is what's called ST T-wave discordance. We've mentioned that term before, and all that means is that the ST segment and T-wave point in the opposite direction of the QRS complex. So in your picture over here on the right side of the screen, you see you got a nice big tall R wave, and our ST segment is somewhat depressed with an inverted T wave. That's what we call ST T-wave discordance. Now the ST segment in the right bundle branch block might not be depressed all that much, but the right-sided chest leads like V1, V2, and sometimes V3 will still show T-wave inversion. And again, this is important because when we get into MIs later in the semester, in ischemia, the ST segment and T waves are important to kind of take note of for that. Okay, so right bundle branch block has a wide QRS complex with an RSR prime morphology in V1 or V2. You can see that this one doesn't have much of that initial R wave, and that's not necessary. And if you look in the textbook, it'll give you lots more variations on a bundle branch, on a right bundle branch block than that. So just make sure you take a look at that. But this has an S, and what you're looking for is that big, tall R wave to finish things off. Remember, the right ventricle is the last thing to get depolarized. So our last bit of electroactivity is going to be over here on the right. Here's an RSR prime. Here's in V2, and so you can see that that's kind of the morphology we'll get in those right-sided chest leads. Sorry, allergies. All right, same thing here. What we're going to do is, if we're looking for a bundle branch block, the two leads that are most important for that would be V1, because it sits most on the right side of the chest, and V6, because it sits on the left side of the chest. And we'll add more of this when we talk about the left bundle branch block. But in V1, what we see is that we have a wide QRS complex. You start right here at the very beginning of that, and you measure over to that, and you get a width of approximately, maybe it's just right at 3.5 blocks. So it's just wide enough. Remember, we need to have a QRS complex that's at least 0.12 second wide. Next thing we want to do whenever we get a wide QRS complex is that we want to evaluate the QRS morphology in V1 and V6 to see if it fits that of a bundle branch block. Because the other possibility could be just a ventricular rhythm, right? So how do we know if it's not just a ventricular rhythm? One of the things we do is we look at the morphology in V1 and V6. So if you look at V1, remember back to our nomenclature, you'll see that this has got a small R wave, deeper S wave, and a taller R wave. So an RS, R prime, and that would be consistent with a right bundle branch block. Wide QRS complex and the RSR prime morphology in V1 and or V2. And sometimes you can get some T-wave discordance, not so much here. There's a inverted T-wave there, although that one's upright. You still have what's called a right bundle branch block. Making sense? Okay. So axis here, we could do an axis real quick too. What two leads do we look at for axis? One in AVF. So lead one is upright. Which side of that sphere would you color in? Remember, lead one sits directly on the left arm. If lead one is upright, it's pointing towards the left arm, we'd shade in that left side of the sphere. And then if we look at AVF, boy, it's kind of hard to tell, isn't it? It is kind of hard to tell. We might even call this equiphasic. And so, because it almost looks like as if you get this little tiny R wave and a little tiny S wave. What does that tell us if it's equiphasic in AVF? That our axis is going to be 90 degrees away from the foot. And so that could either be lead one, which would be 0, or straight over the other side. Well, lead one is nice and tall, so that tells us our axis is pointing towards lead one, and we probably have an axis close to 0 degrees here. Kind of tricky, huh? All right. Anyway, moving around. All right, this is a notched R wave. This is also consistent with the right bundle branch block. You get this R and this thing that doesn't cross all the way down the baseline, and then the second little R peak. We just call that a notched R because it didn't cross beyond the baseline. So right bundle branch block causes, and I'm not always sure why that happens. The patient may be completely healthy and we have no idea why. An atrial septal defect could do it. Anything that kind of affects the right side of the heart, COPD, pulmonary hypertension, pulmonary embolisms, all could be partly why people develop the right bundle branch block. Questions about a right bundle branch block? All right, moving along. So left bundle branch block, these are less common, but these folks who have a left bundle branch block usually have some type of pathology going on. These are usually some folks who've got some kind of cardiovascular disease. All right, so going back to our phases here, if I can get this to work. Okay. So if the left, all right, if the left bundle is no longer working, okay, We get a wave of depolarization. Starts at the AV node, comes down, and goes down, stops at the left, right? So is that first phase messed up? Remember, the left bundle branch is supposed to fire a little bit before the right, but now the left bundle is not working at all. So yes, that whole septal wave is now gone. What we get is depolarization that travels down the right and then has to travel all the way from the right side over to the left. So we lose that initial septal wave, it's gone, and all we're left with is that the big wave that comes after that. Okay, so the septal wave has disappeared. Go back to here. So phase one, usually caused by that left to right depolarization of the interventricular septum, and it's gone now. The left bundle didn't fire, so we don't get that little septal wave. And when we look at V1 and V6, we'll see that that stuff is gone now. Phase two, the right ventricle fires first, and the wave of depolarization is going to move over to the left, just like it normally would when the left ventricle is bigger. So phase two will still appear normal, but it's going to take longer because it's having to go all the way from the right side all the way over to the left side. So we get a wide QRS missing this septal wave in front of it. And this is what it's going to look like in V1. Now, sometimes you can get a very small septal wave like that. Don't let that confuse you. But in general, what you're talking about is this thing is pretty much gone, and you get a wide QS wave like this. That's a left bundle branch block, what it would look like in V1. Same thing here, look at V1. This one's missing that septal wave altogether. A little better example to understand that. This is a wide QRS complex missing that septal wave. And if you look over in V6, we expect to see the mirror image of that, missing that septal wave and nothing but a big tall R wave there. Okay. And just like the right bundle branch block, you can get ST T-wave discordance in a left bundle branch block. So here we see that the ST segment is elevated above the baseline, and then you get an upright T wave, and that's ST T wave discordance because of the negative QRS complex here. You've got some ST elevation and upright T wave. Okay, so you would look at the EKG, you see you've got a wide QRS complex. You want to know if it's a bundle branch block morphology. You're going to pay special attention to V1 and V6. You'll see the V1 is completely negative. We're missing that septal wave right there, and that's consistent with a left bundle branch block. Same thing down here. You'll expect a mirror image of that, and you see you've lost the septal wave here, and you've got nothing but a big, tall, positive complex in V6. And so you also got some ST T wave discordance where you've got some ST elevation and an upright T wave where you've got a negative QRS complex. Yeah, so PVCs, I mean, a left bundle branch block does look a lot like a PVC, right? But a PVC, remember what that stands for. P is premature. And so if you were to march all these complexes out, you would see that there, in these situations, everything is nice and regular. This was not an anomaly where you have one complex that happened early and it was kind of out of the sorts. And these also have, in this situation, they've all got some P waves in front of them as well. So this is another example of a left bundle branch block. You've got a wide QRS complex of greater than 0.12 seconds. Next thing you want to do if you've got a wide QRS complex is pay attention to V1 and V6. See if it has what we call a bundle branch block morphology. In V1, it's missing that septal wave. It's just a completely negative wave here. Got the mirror image of that in V6 where we've got nothing but a positive wave. We've also got the ST T wave discordance, so completely negative wave here followed by the ST elevation, and then a completely positive wave here followed by some ST depression and inverted T wave. So ST T wave discordance. Let's take a quick look at the axis while we're on this one. So what two leads do we look at for the axis? Lead 1 and lead AVM. So lead 1 is upright. Tells me that my My axis is pointing towards the left, pointing towards lead 1. So take that sphere, if you've got written down somewhere, and you can shade in the left side. And then we look down here at ABF. ABF is negative. So that means it's pointing towards the head. So we'd shade in the top part of that sphere. And the two parts that overlap then would be in the left axis deviation quadrant. So this patient has a left axis deviation. Let's see on that. Last one, we're almost there. This is the left anterior fascicular block. This is the most common. So when just one of the fascicles of the left bundle fails, we get what's called a fascicular block. This one happens to be the anterior fascicle, and it's injured by some high pressures in the left ventricular outflow tract. You may remember that we talked about anyway. So when that fascicle gets injured, you can get a partial block of the left anterior fascicular block. All right, lots of pictures. Okay, so the main thing with this is with a fascicular block is it does not greatly prolong the duration of ventricular depolarization. So you don't truly get a wide QRS complex. But what you do get is a deviation in the axis. And so with a left anterior fascicular block, we're going to look for a left axis deviation, like we just pointed out, and a QRS morphology in B1 and AVL that is either a QR or an R. All right, so let's take a look at this example that we've got over here that's kind of already marked for us. The first thing we want to do is figure out our axis. You look at lead 1. Lead 1 is positive. We're on the left side of the sphere. Lead AVF is negative. It's going to push it to the top side of the sphere. That puts us in a left axis deviation. If I've got a left axis deviation, the next thing I want to do is look to see if I've got this particular morphology in the lateral leads. So what I'm looking for is a small Q and a tall R in the lateral leads. As you can see, they've got it marked for you already here. So 1 and AVL do have a small Q wave and a tall R wave. That tells me I've got a left anterior fascicular block. And that's pretty much it. You'll see these pretty commonly. They're not anything dangerous or harmful. Just something you can kind of make it. And this is another left anterior fascicular block. So what you can see is if lead 1 is positive, AVF is negative, that gives me a left axis deviation. Looking for your morphology in 1 and AVL for that small Q, tall R, which we've got in both of those lateral leads, consistent with the left anterior fascicular block. That's the same thing. And what is this? This is left axis deviation. That's the left anterior fascicular block 2. Positive in 1, negative in AVF. It's a left axis deviation. Look for the QR morphology in my lateral leads here, which I've got. That's a left anterior fascicular block. And it apparently is the last slide of the slideshow. Okay, that was fast and dirty. Questions, thoughts? Not always, but so do bundle branch blocks always come with an axis deviation and vice versa? Not always. Now, as you saw, that one of the left bundle branch blocks did have a left axis deviation, and that can absolutely happen, but not always. So yeah, but it's one of those things that kind of helps us with things. There will be a quiz next week. I think someone will proctor that for you, likely on campus, because there's going to be handouts with that. So that's what I would expect. Yeah, that was what I was trying to think. Alex. That's what I was trying to think of was hypertrophic cardiomyopathy. I couldn't find the word. But yeah, you're right, because we get an obstruction of the left ventricular outflow tract with that. I don't know honestly if it's more likely to see a left anterior fascicular block with that or not, but it does make sense. I mean, you're right when we talk about left ventricular outflow tract. That's the other pathology that comes to mind. So, yeah, what you should expect for the patho test on Friday. I will be able to answer that better when I get done writing the test this afternoon. And once I can get it written, then I can come up with a study guide for you. But that's on my agenda next this afternoon. Welcome. What else? All right, you guys know that even though I'm not in my office, you guys are more than welcome to email me, call me. My phone number is on the syllabus. Honest to God, I don't mind if you call. Now, I may not be able to get to you right away, but a call or text is absolutely fine. So y'all have a great night. I'll miss you all, and we'll talk again next Wednesday.